Welcome back. We have a full day here at PrimaryCare22, and I'm Joe Dunn. I'm with the National Association of Community Health Centers. We are so proud to be a part of Primary Care for America and part of this event because the future of primary care is such an important topic to health centers and their patients. And before turning over to the first panel, I just wanted to provide a brief overview of Knack and community health centers. Knack is the leading voice of community health centers here in Washington. We advocate on their behalf and try to push for policies that assist them and their patients. And really, community health centers grew out of the 1960s and the struggle for social and economic justice across the country. You know, racial equity and health equity is core and central to the mission because a lot of the health centers still to this day go beyond the four walls of the health center clinic, right? They address the social drivers of health. And I think there's really four key points about what makes a health center important. So the first is that they're in areas of high need. Right, so underserved communities, and these are 14,000 sites right now across the country. That's the largest independent primary care network in the country with nearly 29 million people. They serve 9 million children, 1.5 million homeless patients. Second thing is they provide a comprehensive set of services. So primary care, dental, mental health, substance use disorder, enabling services. Those are all really important services that are being provided. They also provide care to all, regardless of the ability to pay. So this is so important because 90% of community health center patients are low income and eligible for sliding fee discounts, and nearly 2/3 are racial and ethnic minorities. So really addressing needs for these types of patients are important. Last thing is they're governed by patient majority boards, and this is something that roots all health center programs and services in the community and really ensures that they're locally driven and have the best interests at heart. So, you know, healthcare workforce across the country has been really challenged over the last pandemic, the last couple of years, and so that is not dissimilar for community health centers. And that's why we're so excited today to participate in this. We're going to have some good panels on behavioral health, primary care integration, on the future of workforce in the primary care setting, and innovations in primary care. So with that, again, just really appreciate the work of everybody, all the partners here, and the ability to be a part of PrimaryCare22. So the first panel, we're going to have, so everybody here at the National Press Club, please reminder to wear your mask, so the benefit of you and others out there. And then for the first panel, I'd like to turn it over to Kristen Ratcliff McGovern, partner at Sirona Strategies, to moderate the first panel on primary care behavioral health integration. So thank you.
Great, and thanks, Joe. As Joe mentioned, we're here today with our group of esteemed panelists to talk about integration between behavioral health and primary care. My name is Kristen McGovern, partner at Sirona Strategies, and I will turn it over to the panelists to introduce themselves in just a moment. And we will go ahead and start here with Dr. Syed from ChenMed, and then move on to Lisa Harootunian from the Bipartisan Policy Center, and Dr. Myers from Blue Cross Blue Shield Association. So Dr. Syed.
Hi, I'm Faisel Syed. I'm a family doctor. I became a doctor specifically to work in community health with patients with little to no resources. I started my career there, and I got introduced to ChenMed while being the chief medical officer at one of the largest FQHCs in the country. We had over 100,000 patients, and I was shocked to see a private company going into the FQHC neighborhoods and doing incredible work with seniors. So I spoke with my CEO about the work that ChenMed is doing in our cities, and he said, oh, this value-based care thing, this full risk thing is just a passing fad, it'll come and go. I spoke with the CEO and CMO of ChenMed about the work that they were doing across the country, and I said, my gosh, I mean, you're basically doing community health with the flexibility of the full risk model. And so 5 years ago, I made the switch from the FQHC space into the full risk model, and I'm looking forward to speaking on this panel about some of the learnings we've had with integrating behavioral health into primary care, because you can't influence positive behavior change without acknowledging the importance of behavioral health being part of the team.
Good morning, everyone. My name is Lisa Harootunian. I'm the Associate Director for the Bipartisan Policy Center's Health Program. And BPC is a nonprofit bipartisan policy think tank. That means that we try to find the best ideas from both parties to develop some policy recommendations that could actually move forward in Congress. And the BPC, we recently hosted a task force, a high-level task force of members that it was co-chaired by former Representative Patrick Kennedy, by former Senator John Sununu, Sheila Burke with Baker Donaldson, and Richard Frank, who's a health policy professor at Harvard. And so a lot of the work I'll be talking about here today will be around the work that we did in that task force.
Hi, I'm Adam Myers. I am a family physician and obstetrician by training. I came to medicine a little bit later than the traditional route, but it was after actually helping to open and operate a transitional shelter for homeless men in the poorest area of Louisiana that I decided to pursue medicine. That says a bit about my inclination and why I went into it, and about serving the underserved, changing the way that care can be provided to people in a whole person way is what I've been about. I am with Blue Cross Blue Shield Association, which is the parent company, as it were, for the Blues nationwide, all of the private insurers. In aggregate, we cover 112 million Americans, and that's 1 in 3 Americans, in case you're counting. And I'm the senior clinician for the Blues. Prior to that, I was chief of population health at Cleveland Clinic, where I worked on their public health strategy, the approach in the primary care space, the transition from volume to value, and excited to be here today because I'm very enthusiastic about the future of primary care, and specifically about the value of primary care in the behavioral health space.
Great, thank you. So that brief introduction gives you a little bit of a sense of the expertise and various perspectives that we have here on this panel. I think this is a very timely and important discussion. Anyone who's turned on the TV or picked up the newspaper in the past few days knows that we continue to have a very active discussion about mental health and behavioral health in this country. Today, I think we are excited to talk about the role of primary care and what primary care is already doing in some bright spots and really innovative ways to integrate behavioral health and primary care, but certainly there is more to be done and more that can and should be built on the foundation that we've already established here to really leverage primary care to its full potential. So I think what we'll do today here on this panel is really start with the current landscape. So what types of integration are happening today? Where are some examples of things that have worked? What are some examples of things maybe that have not worked? And really just sort of get a feel for the current landscape. So I think I will start here maybe with Dr. Green and hear a little bit about his experience, and then maybe Dr. Syed as we talk about what type of integration is really happening today and what does that actually look like out there in the real world. So which one of you wants to go first? Dr. Syed.
Sure, I can go. So ChenMed, we're fully capitated. A little bit of our patients, our average patient's over 70 years old. You're talking over 5 or more chronic medical conditions. They're living on fixed incomes. We're in the same neighborhoods as you find your federally qualified health centers. And so because we're fully capitated, we can focus on prevention and early intervention. And we're able to invest the time that it takes to build trust and influence positive behavior changes. And so one of the big advantages we have being fully capitated is with creating teams that are appropriate to look after the care of some of the most vulnerable populations. And so the teams that we have teams that are built around the doctor-patient relationship. So everything is built around the doctor-patient relationship. And the goal of the healthcare delivery system is not to generate more RVUs. So we've changed the currency of healthcare delivery from generating RVUs to improving health. And you can get the teams aligned around improving health because people can understand, well, improving health means prevention of disease, it means curing disease, and if you can't do either, then you're easing suffering. So when everyone is aligned with improving health rather than generating RVUs, then your team, you have your front desk people who are there to help foster the doctor-patient relationship, you have your clinical support staff, and you have your social workers, your psychologists, and even psychiatrists working together. We don't separate behavioral health from physical health because they're one and the same. You are able to have a much more holistic approach to improving the patient's health. So when the system is separated, then you have oftentimes doctors and psychologists and social workers working outside of the same medical record system. But when they're all working within the same medical record system, or they're all co-located within the same facility, and they're not concerned about generating RVUs or generating billing, and we're in 14 states, we don't have a billing department, then wonderful things start happening. And patients' health start to improve. You don't see patients going to the emergency room for their medical care. You don't see them going to the hospital. And we're seeing this happen all across the country, 30 to 50% reduction in hospitalization. So I really meant it when I said it earlier. I feel that when I'm hearing, I heard Ben speaking earlier, people, we have more enthusiasm about primary care and people going to primary care to restore that sacred doctor-patient relationship. We're running in there to improve health. How refreshing that we're here talking about integrating teams. And you can do that when the teams are focused on improving health rather than generating RVUs.
So Dr. Myers, Dr. Syed has mentioned the importance of integrated teams from the front desk person to all of the clinicians focused on the patient's care. What has been your experience? What does integration look like from your perspective? What do patients want from your experience?
Yeah, integration is interesting. I think we need further integration in a variety of ways. One is a mindset. We in the US tend to separate out the mental health challenges and need for support as being somehow separate and distinct from physical health or other pathological processes. And so we view, even in our training as physicians, I remember things are like considered organic versus functional, supratentorial issues. I remember words like that sort of being thrown around during training to suggest that somehow there's physical ailments that are explainable, and then there's the behavioral health stuff, which is somehow different. That's not reality. That's not what primary care is about. But primary care is about the biopsychosocial model of care that really integrates and views those challenges as one and the same because it is one patient, not two separate components of a patient. So there's that piece of integration that I think is critical for us to change as a mindset in the US. And then there's this rugged individualism that has been part of what we've done in healthcare as well. I imagine, we spoke in an earlier panel about, individual physicians coming out and hanging their shingle, and they were sort of a one-stop shop. And there was a study back in 2009 that came out of North Carolina that said for an individual primary care physician to take care of a panel of patients, of 2,500 patients, and implement best practice in the lives of those patients would take on average 21.7 hours a day. So 21.7 hours a day. So it's no wonder that we're not implementing the best practices in the lives of panels. And so in order to really accomplish that, it takes team-based care. It takes team-based care focused proactively on the relationship with the patients, not on the transaction of the moment. So I agree with my esteemed colleague here that a payment shift toward proactive payment, value-based payment, where you can provide care in a team-based fashion without concern about each and every touch being directly compensable because you're getting paid up front for doing the right thing and producing the right outcomes is critical as we move forward. So I think that's what I mean by integration. It's both integration of the psychological, the behavioral, and the physical within our approach to healthcare, period. It's the integration of teams together and behavioral health support into the teams of healthcare where patients are already coming to their primary care physicians. And it's the changing of the payment paradigm in order to better enable that style of practice that's proactive.
Great. So clearly a big thread to pull there with respect to the financial incentives and how those align or don't align, as the case may be, with the clinical needs. Before we get there, one thing I want to sort of tease out here is really the role of primary care and what the primary care team or physician is equipped to do, but maybe not equipped to do. So thinking about the types of services that primary care can provide and the relationship that primary care has with the patient, sort of where do you see primary care playing a role on the spectrum of behavioral health or mental health services that patients may need depending on the severity or complexity of their conditions? So where can primary care play a role? Where's maybe the point at which there should or could be a handoff to some kind of special specialist?
I'm happy to jump in. So one of the areas we looked at is increasing primary care providers' capacity to address mild to moderate behavioral health conditions. And we want to make sure that you all have the payment necessary to provide the time to work on these issues, that you have behavioral health providers who are actually available to consult when necessary. When it is kind of beyond what someone might feel comfortable treating, there should be behavioral health providers actually available to refer that individual to. And what does available mean? It means someone that actually doesn't have a wait time that's entirely too long. It means someone that is actually taking new patients and someone that has, room to see a brand new patient in a fast amount of time. So, that's one of the major challenges there.
Great. Other thoughts?
Well, I see primary care being delivered in all the wrong places. We're seeing primary care being delivered in urgent cares. We see primary care being delivered in emergency rooms. We see primary care being delivered in hospitals. And there's a culture of viewing primary care with a limited scope. Primary care's, wellness visits, referral renewals, and refilling of medications. Primary care is much, much, much more than that. Public health is our space. Most of the urgent care work is our space as well. When you have the flexibility of the full risk model, doctors find incredible fulfillment with doing most of the non-interventional specialty care too, as within the primary care space. So I feel that, as long as we continue to have this hospital-based healthcare delivery system, we'll keep talking in circles about the role of primary care and the limitations of primary care. When really, once you change that currency of healthcare delivery and you get everyone aligned to improve health rather than bill more, then you'll start seeing primary care being delivered in the home. We're seeing it with seniors. When the pandemic first started, we made a switch. More than 90% of our patients we see in person. Within the first week of making the switch to telehealth and telemedicine, more than 90% switched. Our patients switched to doing telephonic visits, televideo visits, and I don't know. I feel that the conversation needs to be more about transitioning away from our dependence on this hospital-based healthcare delivery system to one that should be able to be delivered in the home or in the proper setting, which is a primary care setting.
I'll just add that I think, I'll just start with a statement. Primary care physicians currently provide the majority of the behavioral health care in the United States as it stands right now. Primary care physicians provide the majority of the behavioral health in the United States right now. So I repeated it because it's important and we forget that. We oftentimes think that it's psychiatrists, inpatient facilities, and albeit those things are very, very important, they are very important for the critical acute stages of severe mental illness. And that's important and we can't do without that. And I would maybe later in the conversation suggest some additional and better ways for us to coordinate that piece of it. But for the other majority of the behavioral health needs in the United States that don't rise to that level of acuity, the mild anxiety, the more mild to moderate depression, it's the primary care docs and their teams that are meeting that need. So there are varied capabilities amongst those teams. Some of it depends on training, some of it depends on personal comfort and expertise, But there's ways to upscale some of that capability. But part of it, what I'm hearing colleagues say, is that there has to be a change as well in the way that care is paid for so that practitioners, whoever they are, have the time sufficient to build those relationships and invest in the patient. There's not a lab test that you can pull out and look at it and go, I see your depression's getting better. It doesn't really work that way. It's in conversation that you determine whether or not people are improving in regard to their behavioral health struggles. And that takes time. And you have to get off of the fee-for-service treadmill, as it were, in order to have those sorts of relationships and build that sort of time in. So I think it's a variety of things, but we cannot underscore enough that already it's the primary care physicians meeting the vast majority of the need that exists right now.
And this is a really good point that I wanted to follow up on. So what does it actually look like in practice? Does it look like, a senior comes in for an annual wellness visit and you ask them, have you seen your family? Do you have friends? Do you have activities? Is it that kind of conversation, the real life conversation about what does your life look like? How are you feeling? And then proceeds from there? Or does it, someone in a mental health crisis showing up at the doctor's office because this has been their doctor for 20 years and this is the only place they know how to go? And maybe it's both, but quite a range there, I'm guessing.
I'd say yes. It is all of the above. There are people that don't know what to call what they feel is wrong with them. And they may, the physician, the team, the primary care team may issue a screening survey of those patients during the intake process that highlights that this person could potentially be at risk. It could be a constellation of symptoms. It could be an affect that is observed when you're having conversation with the patient. It could be the fact that they just seem to be less interested in life and the other things, or not necessarily being fully active and participating in their treatment of other comorbidities like diabetes, hypertension, et cetera. Why work to improve those other areas of your life if you're wondering whether life is worth it? Oh. And I think part of the reason why it's a struggle, people don't oftentimes walk in, chief complaint, depression. Chief complaint, I'm anxious. It's usually chief complaint, something else, because asking for help is hard. Asking for help is oftentimes viewed in our society as a weakness rather than the bravest word that we can use.
And I'd like to build on that. So through our work, we did a poll with Morning Consult looking at barriers to mental health treatment and substance use treatment. And one of those barriers was stigma. Mm-hmm. And that contributes to the primary care doctor being that window and that door to accessing behavioral health treatment. So, having that contributes also to that being the majority of, mental health treatment being provided by primary care providers, as you mentioned. So that's, one thing that I think is going to continue to be a challenge. And, but it is the opportunity for primary care to step in and for changes in payment and training and technical assistance and startup costs to support more integration to better ensure that primary care providers can continue to meet those needs and treat those patients when they do screenings, when it is mild to moderate or within their comfort and training.
I may just do one quick follow-up. You asked specifically, what do patients want? And if you really look at the literature about what patients want to feel heard and understood. They want to understand what is thought to be going on with them, and they want to be part of determining that treatment plan. And they also want to feel like they're being cared for by a team that is communicating with each other and on the same page. That is a very difficult set of things to meet. Heard and understood takes time. Shared decision-making is the second piece. And team-based care, not just within a primary care team, but across teams, across the specialty and primary care divide, across the hospital-based and the outpatient space. And so we really have to do better to connect those things, because ultimately that's what patients want. They assume it's happening, but little do they know that rarely do those connections actually occur.
Great. So I think all of these remarks have helped us see a little bit about the current landscape. So primary care providing the majority of the behavioral health services in this country. That takes time. That takes payment structures that are aligned to allow the time that is required to have these kinds of conversations. We've heard a little bit about stigma as a barrier. What are some, can you all say a little bit more about these barriers? So I think what I'd ultimately like to understand is, we know that this is happening today. How do we address the barriers that prevent it from happening even more than it's happening today? And what do we need to do to really get to this end state where primary care is leveraged to the greatest extent possible to really provide a strong foundation for the behavioral health system that can be expanded upon and really serve as a building block for the future. So stigma, misaligned payment incentives, lack of time, and really our time-based payment system is a problem, is one thing that I've heard. But additional thoughts on other barriers or any of these barriers that we've talked about?
Well, the language of healthcare delivery has also become transactional in the United States. Doctors are providers. The visits that happen between doctors and patients are called encounters. Patients are being called clients. A patient who shows up unscheduled to the healthcare delivery system, eyes are rolled and they're called walk-ins. And so when you change the currency of healthcare delivery, you also change the culture and the language of healthcare delivery. So a patient who shows up unscheduled, the front desk staff doesn't come back. We don't have them coming back saying that we have a walk-in. We say we have a patient in need. And then suddenly, everyone who became a doctor or a nurse, they find what their calling was, and they all rise up to the occasion to help a patient, especially when they're in need. And when you have a culture of prevention and early intervention, guess what happens? Every patient gets a daily text message. Every patient gets a weekly phone call. Every patient has a routine monthly visit with their primary care doctor because their primary care doctor knows them best. And so you don't wait for the crisis to happen. You prevent, because they don't come saying, hey, I've got a chief complaint of depression. It doesn't happen. It doesn't happen that way. And so you're able to prevent the crisis from happening because you become their most trusted person. Oh, and every patient has their doctor's cell phone number. That's how you got to start with restoring the doctor-patient relationship and restoring the trust in the primary care delivery system.
Now, one of the things I want to ask about is it really gets to the issue of workforce. So I think one of the key takeaways from this panel so far is primary care is doing a lot, and let primary care do more. We've also, it's undeniable, again, talking about things that are on the front page, undeniable that we have an issue with burnout amongst our medical staff, an issue with workforce shortages. So how do we square those two threads? So we want to do more, but we're also burnt out and there's not enough of us. How do we square those? And what do we need to do to really make sure that we can, again, sort of find a middle ground there that threads those two needles?
Well, I think it's workforce in a couple of ways. We do need more primary care physicians, and prior panels have talked about the workforce and how do we invest more in that. But I could almost say that we need additional workforce in other areas and ways as well, on nurse practitioners, physician assistants, behavioral health social workers, and do we even create a new category of specifically behavioral health support? For instance, behavioral health trained community health workers that can go out into communities and be that first touch, that first relationship where people live, work, learn, play, and worship. I think thinking creatively about that, and then have those community assets and community team members connected to the ambulatory space and then connected to the inpatient space, where it becomes clear that severe mental illness exists and that the need for inpatient care exists. One of the other things I think of is we haven't really coordinated our assets well across the behavioral health space, period. And I think back to other real significant challenges that have existed. For instance, trauma care wasn't very well coordinated for the longest time. It's better now because we've regionalized trauma care. There are criteria for how trauma is measured, about how trauma care is adjudicated, about how regional resources are metered out and apportioned, because it's one of those challenges that is a community challenge that no one provider system, no one clinical system is going to be able to meet. I think of transplant care. It's been regionalized in a similar fashion. Even blood banking has been regionalized as well and adjudicated, where there are standards and measures about how those things are done. Behavioral health, specifically on the inpatient side, but even on the ambulatory side, especially on substance use disorder side, I wonder, do we need something like a regional trauma registry approach and regional adjudication on the behavioral health side? Because we haven't done this organically as individual players in this space. I think we need some other person, and I'm looking at you maybe, to come in and suggest that maybe a regionalization of behavioral health in a similar way that we've done with trauma could be a way to make some sense of this as well. Then there's one final thing I'll mention as well. We don't measure quality of outcomes in behavioral health very well. There are outcome measures available, but we don't require them. We don't report them. They're not gathered oftentimes. You don't find them in the electronic medical record. And if we want to create value and emphasize not just provision of care, but impact and value in the behavioral health space in the same way that we're emphasizing that in the more traditional clinical care space, emphasizing and developing additional outcomes quality measures in behavioral health will be critical.
Right, so checking the box of whether a screening occurred or not is maybe not sufficient.
Correct.
We need to go beyond.
Am I actually getting better?
Yeah. Yep, and I know, Lisa, BPC has done a lot of work around sort of where we need to go and thinking around ideas for improving the current situation. So I was wondering if you wanted to share a little bit about those recommendations.
Yeah, a lot of them build on much of what you said. You know, we want to increase Medicare coverage of different provider types, especially leveraging and relying on peer specialists, which have been found to be very effective, and incorporating those in treatment teams and integrated teams. And then also diversifying the workforce, investing in public and private partnerships that can recruit individuals from underrepresented communities and have those partnerships between medical schools and local organizations to really increase the pipeline and have a more diverse workforce as well.
Great. And one of the things we haven't touched on yet, but I'm hoping one of our panelists or more can weigh in on, is the idea of telehealth. So during the pandemic, I think, and even before the pandemic, and as we move into this new post-pandemic stage, whatever we're calling this now, telehealth has been used, I think, quite effectively, and the data shows it's been used quite effectively for behavioral health specifically. So what do we need with respect, what does a post-pandemic telebehavioral health kind of world look like? How should telehealth be used to address behavioral health needs by primary care and others?
The technology should not be a barrier to the doctor-patient relationship. Really, we're seeing that the technology, especially with the senior population, can very well be an extension of the doctor-patient relationship. We have seen incredible just interactions between doctors, the care teams, and the patients. Many of our patients live in settings where you can see in their homes where they're, risks of falling. You can see where they're going when they're waking up in the middle of the night, walking from their bedroom to the bathroom. We can see like where they're living. We can see what's in their pantries. In many ways, it feels like that the old doctor-patient relationship, when the doctor used to go to the patient's homes, we're able to do it now within the full risk model and using telehealth as an extension of the doctor-patient relationship. I get to experience it being a practicing physician, and I get to hear it from my parents who are also patients of ours. So I get to hear from both sides, and it's just another way to restore that relationship rather than being a barrier.
You know, I was at Cleveland Clinic during the majority of the pandemic as chief of population health. And in that role, one of the things that reported to me was a lot of our online and virtual care presence, about 80% of it. We saw very quickly virtual care rise from less than 2% of our overall book of business on the ambulatory side to 80% or more. The primary care side's dropped down closer to 20% now, but the behavioral health side is still around 80% because it works. It's convenient, it works. People don't have to face maybe that sort of stigma moment of they're walking in and sitting in the lobby of the psychiatry office and looking around and going, what do people think is wrong? You know, all those things, all of those awkward moments are somewhat minimized. However, what it does bring to mind, though, is health equity. There is a digital divide in the US right now where a lot of people of color have more limited access to broadband technology and therefore more limited access, especially during the pandemic, to care, to school, to employment, to you name it. And so the social distancing has led to emotional and economic distancing for people of color in a way that has been very disparate. And we've seen that play out. So that if we're going to have an ongoing emphasis, which I hope we do, on technology as an enabler for behavioral health, we also have to better resource people of color and people who currently experience disparities to have that access that many of us already have, but others do not. And so that's, I think, an important part of what we can think about from a health equity standpoint moving forward.
Great. Okay, so before we wrap up, I think I want to put a point on some of the recommendations. So we've got a fairly robust discussion about the barriers, and I'd like to translate that to action because that's the only way anything will get done. Is if we have some clear call to action for Congress or the administration or all of us acting collectively on behalf of the patients and people that we serve. So. Dr. Myers, your call to action, can you give me a snapshot of the couple or a handful of things that you think would be most impactful here?
Health equity and digital divide, I think, will be critical as we move forward. Regionalization of severe mental illness and substance use treatment. Emphasis on the collaborative care model where primary care resources are truly integrated with behavioral health support and members of those teams, a workforce development from the standpoint of primary care as well as behavioral health, and growing new members of the workforce, such as community health workers, and the emphasis on quality. I would say quality really needs to be brought to bear in this space because it's not just about getting care to people, it's ensuring that there's impact.
Lisa?
Yep. A big part, I think, is going to be leveraging existing value-based payment systems, looking at Medicare, Medicaid MCOs, looking at Medicare ACOs, and where can we leverage those quality requirements to really incentivize and encourage and require integration. And then on top of that, looking at diversifying, growing the workforce, and then also how can we improve access to telehealth, ensure that the flexibilities that we've enjoyed and we've seen real benefits from over the past 2 years continue, and removing barriers to that access as well. Dr. Syed.
Okay, if I had to, I would say number one, increasing the time that primary care has with their patient interactions, and then not only increasing the time, but also training the primary care delivery teams with how to interact with patients who are resistant to prevention and early intervention. You know, when we talk about medication compliance, you know, we're still at 50% in the United States, and that number hasn't changed for 40 years. And even when you look at influenza vaccination rates, up until recently, we haven't even crossed the 50% mark with influenza vaccination rates. So how to engage with patients who are resistant to change, you know, probably more motivational interviewing, training, you know, making that part of not just something that's, you know, for the psychologists and the social workers, but really everyone who's involved in the primary care delivery system. So increasing the time and then also increasing the training with how to to engage with patients so that you can actually move the needle and improve medication, things like medication compliance and influenza vaccination rates.
Can I add one more? And that has to do with that simple word of help. I think we do have a stigma issue in our society where asking for help, period, is viewed as a sign of weakness rather than bravery and strength. And so transition in that regard, I think, is important for us to create that safety in order to ask for help. Part of that will come from viewing this as part of our struggle as people and not that sign of weakness. But if we're going to do that, if we're going to open the door and make it safer to access care, we have to ensure that the access and the capacity is available to treat that. Otherwise, we'll just simply be reinforcing the message that they're not enough.
So I think we've heard collectively the wish list for primary care. I think we would be remiss if we didn't acknowledge that there is an important interaction here for patients who have more complex, serious conditions between primary care and specialty behavioral health care. So for some patients, there will be a point at which there does need to be or should be a handoff between primary care and behavioral health specialists. And I think one of the things, Lisa, you mentioned earlier, was making sure that there is availability, a real-time availability for that handoff to occur, whether it's to transfer the patient to facility-based care or some other kind of specialized outpatient care, but really making sure that there is a place where primary care, once we're at the max of what the primary care relationship can or should handle clinically, to refer the patient. So can we say a little bit about sort of how often, how often does a primary care clinician find themselves in a position where they need to do a handoff to a specialized type of provider? Is it really just a workforce issue that prevents those handoffs from occurring? How can we make sure that the patient continues to feel tied into their doctor-patient relationship even after that handoff occurs? And what really needs to happen on the specialty side of things to make sure that there's this specialty network there to receive the primary care handoff?
Yeah, we're familiar with the patient-centered medical home. It's a great concept. It is great in practice when actual transformation occurs in the primary care setting in order to create that. But the patient-centered medical home will not necessarily be able to meet all of those needs. One of the things that we did at Cleveland Clinic was we created medical neighborhoods, not just medical homes. And that was a sort of that overlapping shared space, the Venn diagram, where specialty care collaborated very closely with primary care. And behavioral health is an example of that. And one of the ways that we facilitated that connection was through e-consults. Our specialists essentially designated a person on their team that would be available acutely and immediately from wherever they were. They were not necessarily otherwise booked with patients, that was available for e-consults, on-the-fly questions from primary care teams to say, I have this situation going on, I need to phone a friend, essentially. Can you help me understand, would I adjust this medication? What's the next best thing to do with this person? And there was no payment for that. There were no RVUs associated with that, but it was the right thing to do for the patients. And it's that sort of connection between the primary care space and the ambulatory and the acute space that I think is critical as we move forward.
We have the same. We curbside.
Yep.
We have it's all internal.
It's a formalized curbside.
That's right. That's what it used to be like.
Yep.
Everyone would just talk you go to doctor's lounge, and most of the time the primary care doctor, you already knew what to do. It's just getting the reaffirmation from the specialist. And with technology, and the communication, you can do that. You can curbside.
And to also increase the number of specialists who are available, one of the areas that I think would be important is improving those network adequacy standards in both Medicare, Medicare Advantage, Medicaid MCOs, and also improving alignment of those standards across payers. Right now, there are some significant variations, and it's complicated for for providers, for health plans, for states. It makes it difficult not to have that alignment across payers. And then also in recent years, we've kind of moved away from incorporating time and distance standards, which can be very important for certain communities, particularly if you're in a rural community. That distance and time to provider is important. And then also making sure that we're capturing those measures of wait times, of how many providers are actually accepting new patients, and how many, what the patient to provider ratios are in those networks as well.
How important is it to have a shared set of quality measures and metrics? Because one of the things that strikes me as we talk is we've talked about the need for value-based arrangements for primary care to give primary care the flexibility to do more when it's a lower acuity condition. But our system is really still set up to put primary care in its box and specialty care in its box, and everybody has their own box with their own metrics, their own payment system. So how important is it to really blend those things going forward to create a more holistic sort of end-to-end experience for the clinicians operating within these systems, but also the patients, so that there aren't these sort of artificial cut points where it becomes someone else's responsibility or someone else's metric?
Yeah, I think it's similar actually to the relationship between bundled payment models and total cost of care models, and I'll say why. Within a bundled payment model, there is incentive to be efficient within that discrete episode of care and for a period of time beyond. There's no incentive to just not do that care in the first place. So there's a total hip or total knee bundle, but there's not the total I end up not doing a knee bundle. And so I think it's the relationship to total cost of care contracts that as a hierarchical arrangement within which episodes live that I think makes the difference and sort of adjudicates that issue. In the same way, I think there is the opportunity on the quality side to say for discrete things, for instance, for outcomes of a total hip or a total knee, having people's return to normal function is an appropriate measure after that type of event, that type of surgery, that kind of intervention. But also diabetic control through that episode is important as well because it's impactful to healing, it's impactful to overall outcomes. And so I think there is an opportunity to connect what is viewed as oftentimes primary care measures, even within the specialty space, to where there's shared accountability for them as well.
And I think creating a foundation for those behavioral health integration essentials at the federal level is important. So making sure that there are more standard measures of what behavioral health integration should look like, what it means, and having that trickle down from the federal level into all the programs and having more alignment across those programs in terms of Medicare, Medicaid, and marketplace plans as well.
When you stop thinking of primary care as the tip of the spear and instead thinking of it as the center of the wheel, then suddenly most of the non-interventional specialty care is being done by the primary care delivery system. And you really only view, you only go outside if I need you to do this endoscopy or this colonoscopy or whatever. And by the way, you don't need to tell the patient you're going to do that. I'm going to send the patient for you to go do that. And you don't need to tell them the results. I will tell them the results because I'm the patient's primary care doctor. So I think the mindset shift too of the capabilities of primary care and not separating, hey, this is mental health, this is physical health. I mean, really, it's all holistic. We need to shift in our minds that we're not the tip of the spear, we're the center of the wheel.
So we've covered a lot of ground in talking about what's happening today, what's not happening today, why it's not happening, and our wish list of all the things that all of us collectively need to do to make the situation better and to leverage primary care to its max capacity. I'm going to put our panelists here on the spot to say the one thing, if they could boil it down to the one takeaway that they want everybody to walk away with in a minute or less, what would be the one thing that you would want the audience to walk away with? And Dr. Myers, I'll start with you.
Team-based collaborative care.
Behavioral health integration is incredibly important, and incentivizing that through value-based payment that encourages and drives integration forward through quality measures is going to be very important.
When you incorporate mental health into primary care, it removes a lot of the stigma that we see today, and it strengthens the doctor-patient relationship.
There you have it. Strengthening the doctor-patient relationship through team-based care that is facilitated and made possible by value-based payment.
There you
To
go.
wrap it all up, so thank you to our panelists. Thank you to Primary Care for America and AAFP, and we hope this conversation has been helpful in sort of thinking about all the various threads and work that needs to be done to really build on the primary care foundation. So, thank you.
Thank you.